Okay, so the Silver Tsunami, Safeguarding the Oral Health of Older Adults. And this is a program that I love to present because it's a program near and dear to my heart. I really enjoy treating this patient population because there's so many of us. Notice I say us. We're going to take over here pretty soon in terms of the population. The impact of aging, the Silver Tsunami. America needs 15 to 30,000 geriatricians to adequately care for the current population of older adults. We have about 8,000 working now. It was thought by 2020 we would require 45,000. People are living longer. Most older adults are community dwelling. Many are staying home longer, if not their entire lifespan. And between 2000 and 2050, 65 and older population will grow from 12.43% to 20.65%. And the 85 plus population is going to grow from 1.51 to 4.9%. 1/4 of the population will be over the age of 65 by the year 2050. By the year 2025, which is not that far off, there will be more older adults than there will be children under the age of 14. But currently, 70% of our older adults, 23.2 million older than 65 years of age, live in the community. They visit the dental practice independently. And of course, we talk quite a bit about the oral systemic link, but I think it really is demonstrative in our older adult population. What happens in the mouth doesn't stay in the mouth. Common findings that we find in geriatric medicine and dentistry: a high prevalence of chronic illness, frequent use of medications, difficulty in getting a complete history, and difficult to obtain appropriate consults. You know, sometimes when you ask for a medical history with our older adults, and they're usually very meticulous, they're going to bring in a list for you and it's going to be very detailed. But it can also be, I call it the Unabomber's Manifesto. It's huge, it's long, it's complex. We don't have enough hours in the day to review it all. But we do know, and we'll talk about xerostomia and other conditions, that when you see a list like that, that should really signal to you that we do need to take a little deeper dive, because some of that is going to affect their oral health and what we see in their evaluation during that time. So unique issues caring for older adults: multiple comorbidities, polypharmacy, xerostomia, varied presentations and prognoses of different conditions common to older adults. We know that older adults are retaining their teeth longer. Most evaluate the patient's oral health in context with, we must evaluate with social, cultural, and educational, economic, psychological, dietary, and life experiences. But ultimately, it's about quality of life. And that's what I'm going to emphasize for all of you this evening. So this could have been 30 years ago or longer. This could have been the norm. But because of improved oral care, baby boomers, which is who you all are treating now, we boomers have aged out. We're aging out at an incredible rate, have had access to dental insurance and extensive oral care. But obstacles occur once institutionalized or hospitalized when caring for their investment. I want you to understand this, that your older adults that you're seeing right now, many of you may sometimes be disgusted by the oral hygiene. You may be judgmental. Try not to be, because you have to understand, for the most part, this generation that you're going to be seeing more and more of are extremely proud of their oral care. They've invested thousands and thousands of dollars. Many of us did not have the benefit of fluoride growing up. Many of us had multiple caries. I myself had caries in every molar of my mouth, my secondary dentition. I mean, this is the norm for many boomers. And so we're on our third, fourth full mouth rehab. We are actually valuable to your practice, but you have to get past looking at older adults as possibly a bother or the hygiene is poor. Because once there is a medical obstacle that can occur, that can be a huge setback for the oral health. And we're going to be talking about that. It can be a setback for the nutritional status, oral hygiene, and so forth. So again, these are folks that often have invested thousands of dollars. And once they hit a bump in the road, I like to call it, that can be an obstacle to caring for this investment, and they're going to depend on you. State-of-the-art dentistry is more accessible. If you drive through the Phoenix area, especially in the West Valley, you'll see a lot of these billboards, the all-on-4 dental implants, 2 to 3 visits, some are same day, etc. I'm going to tell you factually, having treated this population, that many of this population go on to develop dementia and other forms, Alzheimer's, for instance. Many of them find themselves in memory care units. And the question is, who's taking care of this? That's a big problem. So these are folks, again, that have invested thousands and thousands of dollars and become memory care patients, and they lose it all. So dementia, again, we're going to be looking at a quick video about dementia. How many of you in this room this evening treat patients with dementia? Just yes or no? Every day, great. Yes, lots of yeses here. What has been your number one, I would say, challenge for treating dementia patients if you do? Home care, frustrating. Yes, it's very frustrating because they're dependent on others to assist them. For the most part, I mean, early stage dementia is a little different, but getting caregivers to care, getting caregivers, a very good point, Cheryl, and also getting caregivers that are trained, because caregivers are not trained to provide oral care for the most part. So let's look at a quick video here. And this is a video on dementia awareness. This is called The Visit. This is actually an actress, believe it or not, but she is so good at what she does. And she is at a dental visit. So let me not give you the spoiler alert here, but it's a few minutes long, but I think it's important to review this. So I will be on mute, and then we'll come back and discuss.
Now that's all we need to do today, but I would like to see you again in 6 months' time.
Oh, thank you, Dr. Chandler.
And enjoy the reunion. The school reunion you were telling us about.
Oh, yes. Yes, I will.
Hello. Appointment at North LA Dental Surgery on the 14th of March at 11:30. If you are unable to attend, please contact
Hello.
the surgery on 020-8392-9400. To hear this message
Hello.
again, please call
Hello.
07953 966 066. Thank you. Goodbye.
Hi, darling. Yes, I'm going to leave at 10. Yes. Yes. At midday. In reception. Fine. Okay, I'll see you then. Right. Okay, thanks. Bye-bye. Leave at 10. Anna, midday. Let's write that down. Leave at 10. Leave. 10. Leave at 10. Leave at 10. Leave at 10. Leave at 10.
Good morning, Mrs. Reese. Are you all right, Mrs. Reese?
Dr. Rashid is running a bit behind, but you'll be all right. And I can see that you have an appointment with a hygienist afterwards.
Yeah, I do.
Can you please take a seat?
Sure.
Can I help you? Can I help you? Can I help you?
I have an appointment with Dr. Chandler.
Dr. Chandler doesn't work here anymore.
But I have an appointment with Dr. Chandler.
I'm afraid he left last month. He sold the practice. Dr. Rashid is the new owner.
Rashid.
What's your name?
Mrs. Reese.
I've got you down here to see Dr. Sharma.
Sharma?
Your appointment isn't for another half an hour. You can go away and come back in half an hour, or you can wait in reception.
I think I'll wait here. Thank you.
Would you mind filling in the form while you wait?
Oh, yes. Okay.
Can I help? All right, okay. I'm afraid we're completely booked up today. Tuesday is a possibility. What time are you thinking? About 1. Yes, I've got 1 o'clock free.
Mrs. Reese! Mrs. Reese, are you okay? Okay, Barbara, shall we go through? And then I can introduce you to Dr. Sharma.
Oh, yes. Yes, okay.
Is Anna going to be picking you up later?
Yes, I think so.
Just 2 minutes and I'll be with you.
Are you okay, Mum? Are you okay, Mum?
Barbara, are you okay? Are you okay, Barbara? It's okay. Come on. Shall we just sit down here for a while? Are you all right, Barbara?
Oh, yes, I'm sorry. I'm fine.
Do you think you could go and see Dr. Sharma now?
Yes, okay. I think I'll just take my coat off. Thank you.
Just down here. The last door on the right. You know, last time you were here, I think you were just about to go to a school reunion.
Somebody's brought in your medical history form. Now, let's just go through a few things. Are you attending or receiving treatment from a doctor, hospital, clinic, or specialist?
No,
Are you taking or have you taken steroids in the last 2 years?
no,
And are you allergic to penicillin?
no.
I see from your notes that you've been taking warfarin.
Yes.
Okay. Are you still taking it?
Yes.
Okay. And do you have your yellow book with you?
Yes, I have. It's in my handbag. I can't find it.
Don't worry, Barbara. Just remember to bring it in the next time you come in.
But I normally always...
It's fine, Barbara, really.
Okay, now I just need you to sign a couple of these forms for me. Do you have any pain or have you been experiencing any difficulty with your teeth at the moment?
No.
Last time you were here, I think you were just about to go to a school reunion.
Are you all right, Barbara?
Are you all right, Mrs. Reese?
Upper left 8 missing, 7 missing, 6 MOD amalgam. Can you just open your mouth a little bit wider for me?
Good morning, Mrs. Reese.
3 buccal composite, 6 MOD amalgam, O
Good morning,
amalgam.
Mrs. Reese. Are you all right, Mrs.
6 MOD amalgam. 3, 2, 1. Okay, Barbara, let me just show you. Could you hold this mirror for me?
I need to go home. I just want to go home.
Barbara, everything is okay. You just need to calm down.
You can't keep me here.
Barbara.
You can't keep me here.
Barbara, it's okay. Barbara, it's okay. Anna's coming.
Anna?
Anna, your daughter. She's coming to collect you.
Collect me?
Yes, she's coming to take you home.
Take me home.
Yes.
Yes.
Now, don't forget your denture, Barbara. Okay, so if you'd like to take this form back to reception for me, and they'll sort out the paperwork.
I see.
Okay.
I see.
Here, let me help you with this.
Oh, thank you. So, I just need to make another appointment.
Tell you what, why don't I come through to reception with you?
Oh.
It'll be good to see Anna again. How are the grandchildren these days? They must be almost teenagers by now.
Oh, dear, something like 11 and 12, I think. When will I need to come back?
Well, let's go and talk to the receptionist and work out what's best for you. And also perhaps Anna can tell us what works best for her as well.
Yes. I'm sorry. I made a fuss earlier. I just get a bit muddled.
Really, doesn't matter, honestly. It's fine, Barbara.
Thank you.
Okay. I have some questions, but what are some of the comments here? We have a lot of people are saddened by this. I look at it as an opportunity for many of you, but any other thoughts before I have a couple of questions? I mean, this is unfortunately going to be more of the norm. I can't tell you how many memory care facilities are being built across Phoenix, Arizona, and Arizona in general, because the wave is coming. And just statistically, we know the numbers of dementia. We know this wave of baby boomers. So it's something that dentistry really needs to be prepared for. And I have a couple of questions for you. So what did you notice about the instructions for Barbara? She was struggling. What could have been done? If you're familiar with dementia, that could have helped her. Write it down, possibly. Remind her. So when you're giving instructions to someone with dementia, it's better to give one step at a time. If you're giving multiple instructions, it can be really very, very confusing. But here's the thing that you have to understand. There are a lot of folks saying that she needs a caregiver, she needs to give a daughter to help her, whatever. In these situations, the patient doesn't just wake up one day and the family decides this is the day they need a caregiver, right? It's a continuum. And sometimes it takes family members a little bit longer. Now, the daughter was going to meet her there, so the daughter did call her and remind her. But obviously, when you saw her home and so forth, it's questionable whether she should be living on her own. In many families, you don't know that until it happens, right? So we have to be less judgmental about this. So yes, so having someone there that can oversee the instructional process is really important as well. Either a caregiver or family member, both, power of attorney, whoever it is, should be there. What did you notice about the sound when she walked into the operatory? Anybody remember? It was loud. It was hard to hear. It was a little irritating. And many of these patients in early stages of dementia and further on, sound is a really important factor. Colors are also a very important factor. And what about the mirror? Why, when she looked in the mirror, she became almost panicked? What caused her to be panicked and want to run out of the room? I've got a question from Joyce here. Joyce, I'm going to move it over to the other side and address it in a little bit. It was overwhelming to her because she didn't recognize herself. She knew then, you know, there was something wrong. She was looking in a mirror and she didn't recognize herself. Yes. So she was having hallucinations, which is very common, and so forth and so on. So this is a good way to kick this off. What I'm going to tell you about dementia is that if you haven't had the opportunity and you intend to treat our older adults, and I hope you will, there is actually quite a bit of treatment you can provide to this population if you complete dementia training. The Alzheimer's organization is a good place to start. So you can get certified in dementia training, and it will teach you what to do and how to communicate from your front staff all the way to your back office. It makes a huge difference. And again, there are going to be more and more patients that are challenged by dementia that walk through your front door. So thanks, everyone. I haven't posted all of the answers on the other side, but I appreciate that. Okay, so oral care prevention is important in the early stages of dementia because dementia patients may forget how and why to brush their teeth. They may need caregivers to assist them, and those caregivers are going to need to be trained. Caregivers don't know inherently how to care for teeth or the oral cavity. I was involved in training caregivers in various facilities here in Arizona, and we would take in dentures, partial dentures, bridges, models, and so forth to show them this is a bridge, this is a denture, this is an implant, etc. In early stages of dementia, preventive care is important. There's a lot we can do to offset the catastrophes that occur later. And the patient may not always be a willing participant. But with good dementia training, there is still quite a bit that you can provide. Tracy brings up a good point about the floor patterns in the video as well. That's so important. Leaving the office and going home is a huge issue because it's a logistics issue, right? There are more people that spend time brushing their dog's teeth than they are perhaps brushing their parents' teeth. So this is a problem that we have, especially in this country. So I think Jean, wondering about her family and so forth, again, it's a video. So I know in my own personal experience, every day was a little different, right? And one day you hit a bump in the road, and you realize that the things have to change. And you have an entire family behind this. So there are a lot of personalities you're working with. Yeah, nursing homes are a huge problem. And I'm sorry to hear that, Karen. Okay, so let's talk about why oral care is important now for older adults. Because it affects the ability to consume and enjoy an adequate diet. It can affect body weight, impacts nutritional and systemic health, the links between periodontal disease, cardiac health, respiratory conditions, diabetes, stroke, and link to fall risk, as well as the link to dementia. Dental care for the complex older adult is no longer denture care. Access to care can be physical, geographic, medical, cognitive, and financial. Now, I oversaw and provided care to many, many older adults living in place, as well as various skilled nursing, long-term care, group homes, and so forth. Our setup was a little different than this, but this is somebody who obviously has mobile care or mobile equipment and took it into that patient's home. And for patients with dementia, they do very well, often being treated in their own surroundings, rather than being picked up and transported somewhere or put on a bus and that sort of thing. Okay, so common oral conditions: xerostomia, of course, dry mouth, root caries, periodontal disease we see. Institutionalized older adults are at particular risk for poor oral health. Nursing staff and others rated oral care as important. However, there are other activities that are given priority over oral care: podiatry, the hair salon, you name it, jewelry sales. Oral care is not considered part of nursing care. It's often omitted from care plans. It's frequently unclear as to the responsibility. In any facility here in the US that takes federal dollars, they are to provide a evaluation of that patient, which is called a resident guest, prior to admitting the patient. And so for their ADLs, oftentimes they should have a dentist reviewing that patient and providing a comprehensive examination, but instead they don't. They have nursing staff or a physician, and they have no idea what they're looking at. So I would see in the chart, teeth look fine, not very clinical, and would find out later that the patient was wearing dentures and those dentures had never been removed. So there are issues here, and I see some of those of you are commenting on that. Okay, so here's a study: readily identifiable risk factors of nursing home residents, oral hygiene, dementia, hospice, and length of stay. These were 14 nursing homes in North Carolina, 506 subjects. And the oral hygiene residents become of concern following numerous studies documenting poor care and outcomes, such that only 16% of these residents received mouth care and only 15% had very good or better oral hygiene. And this is another study from 1997, oral health status and related behaviors of US nursing home residents. So nursing homes struggle providing the care, and it's a multifactorial thing. I was on the governor's committee here for older adults in Arizona. I was the president of the Oral Health Coalition here in Arizona. I was involved in public health, and it's still a problem. I was interviewed on National Public Radio, and it's multifactorial. There is no simple answer to this. It's going to require much more than we are doing right now. Reasons for poor care and outcomes for nursing home residents. This is another study or two. Patients may resist, staff not aware of the health benefits of good hygiene. I can tell you that walking into these facilities, even when we were walking into Medicare facilities that we were going to provide free care, there would be pushback. Why would there be pushback? Because they knew they weren't providing the care that they should be for their patients. So they didn't want the problems to be identified. Also, then you'd walk around and you would see the advertisements for jewelry sales. The wig lady was going to be there, the hair salon, and so forth. But oral care was very guarded in many of these facilities. And so the only way I could really reach the patient was at the top. So I have to meet with the CEO and so forth, and they're very far removed from the patient care, because you have to understand that these institutions, the Brookdales and others, which are beautiful facilities, they're in somebody's investment portfolio. These are owned by corporate private equity firms and so forth. So by the time it dribbles down to the patient level, now you're dealing with nursing staff, medical staff, maybe director of nursing, and it really is up to them and their perception of how important oral care is. But they're all, for the most part, there's a disconnect between the provision of medical care and the administrators. And that's where the challenge is. So challenges here: most retirees no longer have dental insurance, Medicare. There's no dental coverage unless they have Advantage plans, and those are very expensive plans. Adult Medicaid dental benefits been eliminated in many states, although I see a few are bringing it back. Many live at below or at the federal poverty level, so money is a problem. Many have a limited understanding of the importance of preventive dental care and its relationship between oral and overall health. Almost half of all Medicare beneficiaries did not have a dental visit within the past year, and higher rates among those who were Black, followed by Hispanic, low income, and living in rural areas. Most people on Medicare do not have dental coverage. Many go without needed care, and there's a breakdown for you. 65% no dental coverage, 49% had not been to the dentist in the past year. 19% spent more than $1,000 out of pocket on dental care, and 15% had no natural teeth. And here's some more statistics for you. Many of you may not be aware of the incurred medical expense. Many of you may be, but it's an option to assist with paying for oral care as a nursing home resident. It's actually posted on the American Dental Association's website. This is a toolkit if you're looking for a way to treat older adults, nursing home residents. Here's an option for them to be able to afford some of this care. It's a federal law that allows qualified older adults living in nursing homes to pay for dental care, and it may help to pay for other healthcare services, eyeglasses, hearing aids, even some insurance premiums. So residents who are eligible for Medicaid will often use their Social Security checks or other income to pay for their monthly nursing home costs. The IME can change that resident's monthly income to pay for dental services instead of the nursing home, and then they get their expenses reimbursed later. You work through a Medicaid caseworker, and that caseworker will increase the amount that Medicaid pays to the nursing home on behalf of that resident each month. It will cover dental services that are medically necessary, and at this level, the majority of them are. I mean, nourishment is considered medically necessary. It can't be covered by your state's Medicaid program. You do have to work with families, the other medical providers, and so forth. And usually these facilities, again, have a caseworker that are very knowledgeable on this particular topic. You can go to your state Medicaid office for more details about your state's IME. Risk of oral neglect, difficulty in chewing, swallowing, overall nutrition, pain. Pain perception may be impacted due to dementia. It can affect quality of life issues, self-image, communication, social interaction. It's very important for this population to be able to socialize, and to have your oral health just crumble in front of you is very difficult. It often will cause many of these patients to just isolate in their room, and they are encouraged to eat in the dining hall with their table mates. They don't want to. Their breath is horrible. There's nobody caring for them. Increased susceptibility to systemic infection, pneumonia. possible correlation to fall risk, possible correlation to increased dementia risk. Here's a study that links severe gum disease to raised dementia risk. Again, we mentioned dementia training is very important. And the Australian Dental Association and Alzheimer's Australia, they've developed a series of videos, and they're excellent videos. So if you do a quick search on YouTube and you want to learn more, I highly recommend them. Does poor oral health status increase risk of falls? Here's a study that states it does. Having fewer teeth and not using dentures were independent predictors of falls in older females. Oral health and pneumonia. 1 in 10 older institutionalized adults with untreated dental disease die of aspiration pneumonia. And this data is hard and fast. It was found that if one can go in to these various nursing homes and provide oral care after each meal, we can change these numbers significantly. And the link is there for you. So frailty. Frailty increases the need for regular oral assessment, and it's a slippery slope because once the patients reach this point, there's no turning back. You might be able to slow it down. But here's the issue. If you cannot chew your food and therefore swallow your food, and you're dependent on tapioca pudding and Jell-O, your health as an older adult will take a tumble pretty quickly. Not just your physical health, but your mental health, because these patients isolate. The medical staff watches for this. If they see someone isolating in their room, one of the things they worried about is their oral health, and that's when we would get a call. So my challenge always was, how could the physicians see this occurring and the nursing staff? But it wasn't an issue until they fractured a tooth. And usually it was an anterior tooth that they were worried about, because now the family is going to see this and the family is going to want to know what's going on, right? Homebound patients may be unable to attend traditional brick and mortar dental practices. So mobile provision is very important. The homebound patient, mobile care is what we provided here in Arizona. We took the equipment into the patient's room, and the equipment was customized to do that. There's some of the assistants. And they were all trained in mobile care. This is a program by Ann Ross, who's also a dental hygienist here in Arizona. She has these beautiful mobile units here. I'm looking to see if she's with us today. Sometimes she's on one of our classes here. Not today. You'll see some of her photos. But beautiful, beautiful mobile facilities that she travels all over Arizona. She's been doing so for at least, I think, 15 years or so. This was an interview with me in 2018 already by Kathy Ritchie, National Public Radio. Kathy Ritchie's mother passed from Alzheimer's. She's a journalist with National Public Radio. And I believe it's still available to hear. But this was quality oral care concern for older adults in long-term care. And she followed me around for the day, seeing the patients and our hygienist as well. Risk for Clostridium difficile. Patients 65 years and older considered high risk for C. difficile infection when prescribed antibiotics. They're also at greater risk for hospitalization and death. Nursing home residents are often also on proton pump inhibitors. There's environmental contamination, and they may be potential carriers. They're all at higher risk. Learn more about Clostridium difficile by taking a course that I present. It's available on demand and live each month. And also we have a 3.5-hour course on the latest antibiotic in clinical practice, antibiotic stewardship and appropriate antibiotic use. So if you are not up to date on the latest recommendations, if you're still prescribing clindamycin, it's a 3.5 online course by Dr. Tom Palmeyer, who is the co-author of the American Dental Association's antibiotic prophylactic guidance. If you are treating patients in nursing homes, be very, very careful, because your wipes that are quaternary ammonium compounds do not kill C. difficile spores. And you're at risk. If you're taking antibiotics and you're working in these facilities, you're at risk. And we've had dentists that have reached out to us recently whose dental assistants developed C. difficile, no known risk factors, not on antibiotics. So again, take the course and learn more. Here's some case examples. This is Ann Ross's group, Mobile Dentistry of Arizona, and these were all published on the National Public Radio website. But this was a fair amount of plaque here on the anterior teeth. That's unusual to see. Just basic cleansing of saliva normally would take care of some of that plaque. But this was a patient, this is probably xerostomia too, and also a dementia patient that was combative. She was in a memory care facility, so she was difficult to treat. Another example here, of course, is an abscess. It looks like it's number 9. And many of these patients don't complain of pain because they may be on other medications that mask the pain, or sometimes dementia will also mask the pain as well. Christy, the link is there in your handout. Yep, it's probably around slide 48, 49. I just went through it. Yep. Terrific. That's terrific to know. Here's another example also with Ann Ross's group. This is xerostomia, and this was a patient from a skilled nursing facility here in Prescott, Arizona. These cases are so difficult for me because this was somebody that entered that facility with all of their dentition, and this is what xerostomia did for this patient. You can see they're probably also a smoker. However, look, they had a 3-unit bridge on the upper left. They lose it all and probably a partial denture, so the abutments are gone. And your option here is to extract root tips and place dentures that they're never going to wear. So there is sort of a movement in memory care facilities to place implants because there may be better value than trying to fabricate removables that they're not going to be able to use, because nourishment's still important whether you have Alzheimer's or not, right? So here's another situation also, memory care facility. Here's another example, and you can see on that lower right area where the gingiva is completely grown over the root tips. Now, the last thing you want to do is go in and remove root tips. These patients are severely malnourished. This is why we have oral cavities, so we can initiate digestion. One of the reasons we have oral cavities. So when your teeth break off and you're in a facility like this with nobody to really assist you, imagine what your life is like, and imagine what your ability to nourish yourself is like. There's no way. We use diamine fluoride too, so we're diamine fluoride, Kimberly, but the problem here is that a lot of these cases are too far gone. They're already pulpily involved by the time we get a call. This is one of our cases here. This is a patient that entered the facility with their dentition, developed xerostomia, and this is when we got a call, fractured tooth. How can a physician or nurse look at this happen over a period of time? I don't know. That just, I have no words. So one of the things we did here was we trained mobile physicians groups that also go out, because we know who they are, to provide an oral exam, use an intraoral camera, and send us the video so that we could see it. And we worked closely with them, and that made a huge impact. And also the mobile nurse practitioner programs as well. Case example here. This was one of Ann Ross's patients. This was on National Public Radio on the program they were at. This was a patient's denture, lower partial covered in black mold. They did not know that she had a denture. She had lived at the community for over 6 years. Nobody had removed that denture. Here's an example when we were providing weekly preventive treatment. We would send dental assistants in. We called the plaque attack group. They'd provide thorough brushing, flossing, and rinsing. It was only once or twice a week, and the big improvement in the gingiva. So even that small amount makes a great bit of difference. All right, we are at the end, and I want to see if we have some questions here. Majority of the families are not inclined to place implants in Alzheimer's patients. So, you know, there's a degree, Dr. Blank, of dementia. So in some of the dementia patients, the earlier patients, we would make the call. We would give options to the family. And if they had caregivers and they had the ability to provide ongoing care to those patients, some of them did, if we felt that they were a good candidate, would go ahead and okay. And then you'd have on the other side of that, you'd have patients that had rampant decay, needed root canals, abscessed teeth. The family members were in charge of the finances that would not approve the care because, well, that's going to bite into their inheritance, right? So then we have to make a call about neglect. So we had that flip side, you know, and it was complicated from there, going into patients' homes and seeing somebody with maybe pressure sores that needed attention. Those are things that border on neglect as well. So it's not so black and white. Abscesses under the root tips, absolutely. So, you know, what we would do with patients that had root tips that needed root tips extracted and so forth, I didn't jump in right away. I wanted to make sure that we could get their nutritional status bumped up, and then we would go ahead and plan the treatment so they were going to heal. Because my concern was about not just infection, but delayed healing or causing another problem. Yeah, we do have, there are already RDHAPs all over the country now that are providing care in facilities. And yeah, in many areas, money and finances are a huge issue. Do many hospitals or care centers have positions for dental hygienists to be on staff to help with oral hygiene on a daily or weekly basis or to aid in home care? So there's actually a dental facility in San Diego, for instance, and they only treat older adults. If you do Google research on that, I don't remember the name of it offhand, but there are facilities. Now, here in Arizona, I've consulted for many of these facilities. Some of the skilled nursing facilities now they do have some dental care available at least a couple days a week. And in other states, they're in New York. I visited a few of those as well, in Flushing and so forth, in Queens. Beautiful assisted living facilities, and they had on-site care where a dentist would come in and provide the care. Do many hospitals? Yeah. So again, I would reach out. Here's the thing that you have to understand as we close here, and I'm going to be bringing Tanya on in just a minute. We see the need. We see it's required, and many of us say, well, I'm just going to buy mobile equipment, and I'm going to go to these facilities because it's needed. And I'm sure a few of the RDHAPs we have here know what I'm talking about here. It can be a lot more political than you're prepared for. And that's the depressing part, really. You have family members that don't want the care. You may have medical staff that don't want the care because they don't want to be outed. Or you might have a director of nursing. I used to run into this all the time in one of our facilities here. We'd walk in and they'd say, oh, there she is. You know, I haven't been to the dentist in 25 years. I don't have any problems. And you know what? Her patients hadn't been to the dentist either. So it was part of her philosophy that it was not important. So getting out there and educating the facilities, becoming involved, the best way is to find out when they're having events. They always love to have somebody come in and talk, give away something. They'll have health fairs and so forth. Get involved at that level. But I'm not going to lie, it's a difficult process to build relationships with these facilities. Yes, so I used to give continuing education in nursing homes as well, and group homes. Group homes it's a little different deal, Michael, but there's smaller facilities, and they really appreciated it. Yep, they really appreciate it. Shouldn't state-funded facilities be enforced to meet the standard of care? Well, they're supposed to, but enforcement is through various agencies, and it's very difficult. I'm on some committees for that, and you would think it would be the case, hence my reason for being on a national public radio show. All right. We've got a comment here from Dr. Aiken. I'm a dentist of 39 years. I plan to transition out of private practice and into senior mobile dental care. I have a signed contract with our local long-term care LTCC. I'm in the process of signing contracts with 2 other. Terrific. I wish you all the best, and I hope you're able to reach the families, the power of attorneys, and the caregivers to approve the treatment. That's a challenge. In many states, these residents and facilities do have to have a dentist of record, but the dentist of record has to show up. So, and the power of attorney and the family have to approve the care. So again, it's a very complex situation. I am going to bring up the presentation for Tanya Dunlap and introduce her. And we're going to be putting a link up here as well to Perio Protect. So as I introduce Tanya here, I want to thank you all for being here. And this portion is about Perio Protect. It's not required for CE credit. However, I hope you will stay, because this is an excellent technology for many of your patients in nursing home or still living in place. You RDHAPs in California, if you're not familiar with this, I hope you will be. So Tanya Dunlap is a vice president at Perio Protect, where she has worked since 2005. She's responsible for the educational, marketing, and commercial programs at the company. Previously, she served as the Perio Protect research liaison, working with researchers and microbiologists testing Perio Protect in controlled clinical trials. Her expertise on this adjunctive periodontal therapy is grounded in the research data, explaining how the prescription trays work and which patient candidates can benefit from them. Currently, she trains key opinion leaders. She also offers multiple CE courses and trainings on the science behind Perio Protect, looking at the important practice and clinical implications of the research data. So I'm going to go ahead and turn it over to you, Tanya. And for those of you who want to know more, I'm going to have a link here at the top of the screen for you.
Thanks very much for having us and for taking on this really important topic. I want to talk about tonight helping people keep their teeth, ideally for life. I did see some of these heartbreaking pictures in the video as your course went on. And by the time you get to something like this, perio tray therapy is not going to be able to restore everything that we want, but we can help prevent it, and we can help prevent the slide downward that so many older adults face. And let's talk first about a couple of things. One, the tray you see in front of you that has the blue markings on it is the true Perio tray from Perio Protect. It's cleared by the Food and Drug Administration as a prescription medical device. So if you have someone, a loved one or patients that are in a skilled nursing facility and you write a script for this, they are supposed to follow that script. And truly, it's much easier than brushing someone's teeth. Although it doesn't replace toothbrushing, it's not designed that way. I'm saying it's easier. So you just put the gel on the bottom of the tray, and the people wear the tray 10 to 15 minutes. It does not matter if you wear your trays longer than 10 or 15 minutes. I do appreciate that comment about using Perio Protect in your practice, and I am so glad that you are. Are you using it on older adults is the question here. Also, it's important for me to have this chance to interact with all of you, and I appreciate your time tonight. It's easy to do this. You put the gel in the bottom of the tray. A skilled person can do this in a skilled nursing facility. A caregiver at home can do it very easily, much more easily than brushing someone's teeth. For folks who have dexterity issues, if you have someone who can help you, it's a great option. Also, I want to say, because it's not part of the presentation, but I was thinking as I was listening to Dr. Roling, if your patients have dentures, you can put the gel on the bottom of the denture. It's a removable, obviously, just like you see here. You just flip it upside down, put the gel on the inverse of the occlusion there, right? And you would have such a clean denture. And I do have a case study about this from years ago. If I could find those images, I should have put them in this presentation, but it's a great way to keep those dentures clean and to keep the tissue underneath it really healthy also. Right, let's talk about how this works and what our goal is with all patients, but especially with your patients who are older, right? So if you believe that bleeding is super important for patients to take care of, then you are going to want Perio Protect. We know, especially for our older patients who have a lot of comorbidities, it's really important that we keep their gums healthy because the immune system's like a battery. The more things you have hooked up to that battery, the quicker its power fades. If you have a long list of medications also, let's try to treat the gums without adding another systemic antibiotic. We want to be able to address the infections in the gum tissue. You will also be able to address, to some extent, the plaque that builds up on the teeth, the biofilm that is building up on the teeth. Hydrogen peroxide is our primary antimicrobial. So this gel here, Perio gel, it's 1.7% hydrogen peroxide as the primary antimicrobial. Hydrogen peroxide is a really known anti-plaque agent. And in controlled clinical trials, we did not test, we didn't randomize patients for plaque. We randomized them primarily for pocket probing depth scores, and in a different case for bleeding. But we did collect the data, the plaque index data, and those patients, those subjects in the groups using the Perio tray therapy with this hydrogen peroxide gel had better plaque scores than the others. All right, let's go back to bleeding. We know from these long studies that tooth sites that have consistent, persistent gingival bleeding are 3 times more likely to have attachment loss. We know they're significantly more likely to be extracted. And we also know that if we can get the bleeding under control, it is a highly accurate predictor of no further periodontal damage. So said another way, the fact that tissue bleeds is not a great indicator of long-term periodontal damage. It might be a good indicator of an active infection, but not of long-term periodontal damage. But if you can get the bleeding under control, it's a highly accurate predictor of no further periodontal damage. And here's a patient who's 80 years old, and she comes to the dentist every 3 months. And it's been 2 years since she last had scaling. It's a lot of bleeding. We need to be able to address these kinds of infections. And this is what you were able to do with Perio Protect. This is just 2 weeks of Perio tray therapy. Here's the same patient, different version. We didn't get rid of all the bleeding in just 2 weeks. You wear these trays 10 to 15 minutes at a time. And you wear them more frequently in the beginning. So if it's a maintenance patient like this one, you might start her out twice a day. You might start somebody out 3 times a day if they're really involved, but let's say twice a day. And you want to get them down to 1 time a day as quickly as possible. A tube of gel lasts 3 weeks when you use it twice a day. So we recommend that you do it twice a day until you're done with your first tube of gel, and then you go down to 1 time a day. This is the before and after. So with Florida probe charting, which is gorgeous. And I love to be able to give this when patients can take this home, right? You can give these charts to your patients because they're so gorgeous. The red diamonds are bleeding points. If it is a black vertical line, it's 1 to 3 millimeters. If it is a solid red line, it's 4 millimeters. If it's candy striped, it's 5 and up. So this is the same patient. She's 80. Pre-treatment on the left. Actually, it's not pre-treatment. It's pre-Perio Protect treatment. She's had scaling 2 years ago, and she shows up every 3 months like clockwork for her maintenance appointments. And she's struggling, like a lot of Perio patients do. And let's just stop here for a moment and say, a lot of Perio patients struggle. If antibiotics worked well, we wouldn't have such difficult challenges maintaining healthy tissue and healthy gums. They added tray therapy. In 2 weeks, she had really nice results. This is actually her 2-week results. Now you see distal of 2, that's still an 8 millimeter pocket. So this is adjunctive home care. It's not going to take care of everything. But what we want is to be able for this tray delivery system to work fast, and it does, but then to maintain their health, ideally for life. We would like to keep if we can't, if you have crown margins or you have implants and those margins are infected, let's clean up those infections as quickly as we can and then maintain optimal restorative results. The problem for many people, of course, is toothbrush, rinse, and floss, even if they have great technique and dexterity, which we do struggle with as we get older. Toothbrush, rinse, and floss don't get deep enough. What the tray does is gently delivers the medication deep below the gum so that the medication can fight the infection. There are other drugs you might consider for delivery, but hydrogen peroxide gel is our primary antimicrobial. Hydrogen peroxide gel, even at the low concentration of 1.7%, is an excellent broad spectrum antimicrobial. It works against all kinds of bacteria, aerobic, anaerobic, facultative anaerobes, and it works quickly. It's not on contact. That's why rinsing with the hydrogen peroxide product doesn't work quite as well. You need contact time for it to work. And in Perio gel, the products that are made and tested by Perio Protect, needs 10 minutes as its therapeutic time point, but it continues to release oxygen for a full 17 minutes. We ask people to wear the trays for 15 minutes. If you're short on time, you need 10 for it to work. You need 10 minutes to get a good kill rate, but 15 is ideally what we want. Perio gel releases oxygen and activates in a very linear fashion. What that means clinically is you're getting a slow, consistent release of oxygen right until about 17 minutes when the hydrogen peroxide is broken down into oxygen and water. You get a good kill rate at 10 minutes, but that oxygen is really important for long-term health and healing and for the fast results that you see in the initial phase of treatment. And I say initial phase 2 to 3 weeks. Oxygen delivered deep with this tray changes the microenvironment of the periodontal pocket. So when bacteria repopulate, and they will, we never sterilize the pocket with this approach. You are just decreasing the bacterial load and you're changing the composition of the microbiome because you've changed the environment. The addition of the oxygen creates the right environment for healthy bacteria to repopulate. This is what the tray looks like in the mouth. It has a longer extension than you might expect. That extension supports a seal. There is an internal peripheral seal. We like to use probing charts, but if you don't have a probing chart, we can make a uniform seal for you. The seal and the extension works like a gasket. It prevents the medication from leaking out all over the mouth and drives it really deep, uphill and downhill, deep into the periodontal pocket. And also into shallow pockets. So let's just think about this. Typically, your patients have a variety of pocket depths. The full arch approach allows you to address all of it. And it's a really nice option. It's comfortable. It's easy to use. It's easy to clean. And you only need it 10 to 15 minutes a day. However, if you wear it longer than 10 to 15 minutes a day, it doesn't help you and it doesn't hurt you. This is how flexible the tray is. I mean, you could flip it inside out if you want to, but it's super flexible. If you've got really inflamed gums, it needs to be comfortable. And it's easy for people to use. Again, you just put the gel on the occlusal surface of the tray. Here is a patient. She's in her 60s, and she struggles. She's not able to make it to every office visit every 3 months. It is added tray therapy. and she uses her trays pretty much once a day. You want to get people down to once a day as quickly as you can. And there's 6 months difference between these two pictures. You get patients with lots of crown margins. Ideally, we're going to stop this infectious process before they start losing teeth or they break off. You have to replace crowns. With older adults, you know, your crowns have a certain shelf life. Why can't they last longer? They can if you can keep the tissue around them healthy. We're going to give you optimal restorative results. Here's a patient, and you can see this is just 2 weeks of tray therapy. So left is pre-treatment, right is 2 weeks later. Same patient. She's got 15 crowns in her mouth. As Dr. Roling was saying earlier, patients in our current older population, they've done a lot to try to keep their teeth healthy, to do what they can to maintain their teeth. This is going to help them continue into a long-term state of health. We didn't get down to 0 bleeding points. You don't always get to 0, but you should get to single digits with prescription perio tray therapy. And this is true even for patients who have implants. So ideally, when you place an implant, you're going to give patients a set of trays, perio trays specifically. And I should preface that while the tray is cleared by FDA as a prescription medical device, and that's important, it's also the only tray on the market that has years of clinical trials and research. And I used to be the research liaison. If any of you want to talk about this afterwards, I'd love to talk about the data. I'd also love to talk to you about doing some pilot studies with older adults, whether they're in assisted living facilities or you're going out and you have a mobile clinic. Really happy to work with you. We do lots of innovative programs with the Veterans Administration where we give preferred pricing, and we can do the same for you. We just need to have a system, and I'm interested in doing that. And it would be good for everybody. Okay, implants though. Let's go back to that. I like that middle image because it shows how precisely these trays fit. They're not touching the implant, but they fit really precisely. And what you're looking at on the right is 2 years after starting perio tray therapy. For those of you who are helping older adults, treating older adults, and you don't have the option of getting them someplace for SRP or for a surgery, and yes, you can scan. You can scan and have a tray made. So if you're in someplace, so you're in mobile and you can take a scan, that would be best case scenario, easiest, fastest turnaround time. We turn those around in 3 days and send them back to you. But if you're in a place and maybe you can't get them into a facility for a while, hygiene schedules are jammed right now. But let's say you have somebody and they're really advanced like this. This is going to be what we call the IRX approach. So in typical maintenance phase, so gingivitis, periodontal maintenance, you've got lots of infected crown margins, implant, peri-implant mucositis. We start twice a day, 10 to 15 minutes till you're done with that first tube, and then you drop down to 1 time a day. We want you to get to 1 time a day as quickly as you can. This is a patient that we're going to use the IRX approach. IRX, I for initial, RX for prescription. You use the trays first. And it's a 3-2-1. For 2 weeks, you're going to go through a tube of gel in 2 weeks if you use it 3 times a day. That's it. You'll use it 3 times a day. Then ideally they come in and they get some in-office treatment. And then you would continue using your trays. You drop down to twice a day and again, get to 1 time a day as quickly as you can. This is a patient who is not brushing well. He is not flossing. He has some areas of isolated destruction here, especially those lower anteriors. And they use trays first. So, do you see how goopy and soupy this is? This is what hydrogen peroxide does to calculus. So, as a broad spectrum antimicrobial, hydrogen peroxide works by breaking down protein chains. This is how you are able to lyse a bacterial cell wall. They talk about debridement, hydrogen peroxide being a debridement agent. It works because a bacterial cell wall is a bunch of proteins linked together. The hydrogen peroxide will cut through the proteins that are linking the chains together, and it will lyse the bacterial cell wall, and that's how the cells are going to die. Well, calculus is basically a skeleton of protein, and it denatures the calculus. If you use your trays first, if this patient had been brushing, we wouldn't get that beautiful goopy soupiness that helps make my point here. That would be really much better looking teeth, much cleaner teeth. When you use your trays first and then brush their teeth, or the patient brushes his or her teeth, it's more effective because the hydrogen peroxide is breaking down the biofilm on the tooth surface also. This is the same patient 6 months later, still not brushing or flossing the way we want, and yet using trays. Trays feel good. They're easy. They make your mouth feel clean, that you will have the freshest breath of your life, and they will whiten your teeth over time. So here's this patient. We're looking before and after. 100% bleeding on probing down to 6%. I will take 6% for someone who's not brushing their teeth always. Here's a patient, our next one, who is brushing his teeth. And you see, top left is pre-treatment, bottom left is a month of tray therapy. That's just tray therapy. Nice improvement. We really shine on inflammation, but we're also able to help you denature the calculus so it's easier to remove. It's still subgingival. You still have to go get it. The large image is 5 weeks after scaling. So again, top left is pre-treatment, bottom left is a month of tray therapy, no debridement, no nothing, just tray therapy with the patient's additional home care of brushing. And then the enlarged image is 5 weeks after scaling. Same patient, different viewpoint. Top left is pre-treatment, bottom left is a month of tray therapy. You can see some stippling coming back already. And then the enlarged image is 5 weeks after scaling. This tray therapy is designed for patients who have gingivitis or periodontitis. They have implants. You're trying to prevent peri-implant mucositis. It's a really helpful tool. The gel, there's 2 versions. One's the original, the other's X. X is flavored with xylitol. And let's talk a bit about remineralizing agents also. I'm going to talk a lot about hydrogen peroxide, but you can use this tray. The tray is just a periodontal medicament carrier. Whatever you put in it, it's going to push it to the base of the pocket. So we don't want to put any sugar products in there. But if you have MI paste, you have Reminpro, you have Prevident, you've got some of these other really nice remineralizing agents, you can use those remineralizing agents in the tray to help stabilize the teeth, especially your patients with xerostomia, right? Because sometimes your teeth are just crumbling. If you have a lot of root surface exposure because you have a lot of recession, use the trays. There was a periodontist who did a study and he followed patients for a couple of years. And he had them use a fluoride as his remineralizing agent once a week. He told them to do it on Sundays because he thought it was easy to remember. So hydrogen peroxide 6 days out of the week, and then fluoride on the 7th day, here Sunday. And they had many fewer root caries than you would have expected from the literature. So you can use this tray delivery also with remineralizing agents. The hydrogen peroxide at a low concentration very rarely causes sensitivities. It's very, very rare. It debrides the matrix. The matrix is that gooey protective barrier over a biofilm. It debrides bacterial cell walls by breaking down protein chains, and it oxygenates the pocket. It is a really, really nice option. And earlier I mentioned that you needed 10 minutes. Live dead dye study, you grow the biofilm in the lab. This particular study was done at Allegheny Singer Research Institute. Confocal microscope, grow the biofilms in the lab, you expose them to dyes. If they pick up the red dye, they're dead. If they pick up the green dye, they're alive. And you can see these were at Streptococcus mutans, right? Strep mutans are always associated with decay, but the microbiologist chose them on purpose because they create the gooeyest matrix, the gooeyest, it's basically a protective slimy layer, and that protects the cells underneath. So it was a good test to see how long would it take to get through the goo, the peroxide to get through the goo, and then to kill the cells. And remember, you're only killing the surface cells, the ones that come into direct contact. So if you imagine your bacterial community is like an onion, it's really shaped like a mushroom, but let's pretend it's like an onion. The tray pushes the medication deep, and it can get into pockets as deep as 9 millimeters. So, from 1 to 9. It pushes the medication deep into the pocket. The medication will rest, in this case, we're talking about hydrogen peroxide, rest against the exposed surface layer, cut through the matrix, and then kill the cells in 10 minutes. 10 minutes, red is dead here. 10 minutes is your therapeutic sweet spot. The gel continues to release oxygen as it's bubbling up for another 7 minutes. Ideally, you're going to have them where at 15 minutes if you go for 10, it's good. It's a good kill rate, therapeutic sweet spot with 10 minutes of oxygen. Go for 15, you get almost all the oxygen benefits. Your body will eventually absorb the oxygen in the water. But oxygen under pressure is a really great medicinal agent. Oxygen under pressure, remember this tray is sealed on the inside. So as the hydrogen peroxide is bubbling up and it's trapped in the tray, you're increasing the volume pressure in the tray. Oxygen under pressure will help stimulate the formation of new capillary beds. And that's very important because you'll have faster healing, stronger tissue. But you need to wear it at least 10 minutes. If you go longer than that, I wear my trays longer all the time because you just stick them in and go do something else. It doesn't help me. It doesn't hurt me. It's just convenient because I don't have to get up and get them out right away. It does matter what gel you use. Some of the other gel formulas do not, even though they have the same concentration of peroxide, do not work as quickly or as well. And there's one gel on the market that has formaldehyde releasing agents. I strongly encourage you to avoid that one. I want to be very respectful of your time, and I also want to leave some time for questions. I'm going to put my contact information up here. You, of course, can also click on the Contact Perio Protect. There's lots of good information there for you all. If you are interested in the research, be sure to let me know. We didn't go through a lot of research tonight, but we do have 2 controlled clinical trials, a long 5-year study, microbiology studies, and I'd love to talk to you all about that. All right, how can I help my patients afford Perio Protect? Well, we can do something for you, but honestly, I don't know what you're expecting, but your lab fees are really not that expensive. It's around $227 for everything. And if you are treating lower income folks or you're treating veterans, we have special pricing for you. Significant discounts in those cases, just for you. So reach out to me, use my email or call. That's the main office number. Just ask for me and we will be happy to work with you. What's the percentage of hydrogen peroxide? It's 1.7%. So let's put that into perspective. Your lowest whitening agent is 10% carbamide peroxide. That's the same as 3.4% hydrogen peroxide. It's half of that. We did test 3% hydrogen peroxide gels, and they work really well, but they cause a lot more sensitivities. At 1.7%, it's a really gentle way to keep your gums healthy, to oxygenate the pockets. All right. Is there flavor? Yes, there is a flavor. It's mint. We're coming out with a new one in the fall. Perio Gel X is flavored with xylitol, and it's a little less minty. But otherwise, it's got a really nice, refreshing taste, in my opinion. Let's see. How do we incorporate this with molecular iodine therapy? Well, the molecular iodine therapy that I know of and really like is a rinse, and the rinse is great. It just doesn't get really deep below your gums. They also have gel, and you can use that. We've had periodontists test both the molecular iodine gel and the Perio gel, and they said one's not really better than another in terms of like wiping out more bacteria or pocket depths. You get really beautiful inflammation reductions with Perio Protect and the hydrogen peroxide. Plus, you get the whitening effects and fresh breath. So a lot of people like that. But depends on which products you're using. But you can use both of them. Yes, you can use a scanner. Super easy. You take a scan, send it to us 3 days. We turn that around and send it back to you. So, lichen planus, pemphigoid, it's a different protocol. And I do have special help for you. Periodontist in Oklahoma. He was the head of Perio at OU for a while. He stepped down last year. His name is Robin Henderson. He developed a protocol that was published by the Peri-Implant Advisory Group. Essentially, you use your trays as a periodontal medicament carrier. He was recommending lidocaine to get the patients comfortable. Then take it out of your mouth, rinse it. Cold water, you do need to rinse your trays with cold water. Hot water can distort them. Then do Perio gel for biofilm management. Then take it out, rinse it again. And then he was using Lidex as his first course of treatment, but he said Lidex does not universally work. And so you might need some other topical steroids to make that work. We, of course, are not going to be treating the cause, right? But we can help relieve some of the symptoms here. I'm happy to send that. Cheryl, I'm glad you're interested in the pilot program. Please reach out to me. How much gel do you put into the tray? Great question. Not very much. It's less than a gram, and I don't even know how much that is, but I like to say it because it's not very much. You take I don't have gel here. You gotta pretend this is the tube of gel. This is literally how long it takes. You just stick the tube in here and you do a thin line or ribbon on the occlusal surface. That's it. If you put too much in, it'll express out. You'll taste it. It's a nice taste. Spit it out. Put less in next time. You can use this with children, but I don't recommend it because every time the dentition changes, you need new trays. That said, we did use perio tray therapy for our kid. He has chronic acid reflux still. He's 20. He started out with trays when he was 8. We had just chronic decay. We had an endodontic procedure when he was 8, and that's when I was like, that's it. So we had done varnish and fluoride treatments and everything else, but we started using perioprotectant. We just tied it to a shower. When he's 12, it's harder to get him in the shower than the trays actually, but he's good. He was just at the dentist actually 3 weeks ago. No bleeding, no pockets over 3, no decay. I'm happy about this. Compare OTC hydrogen peroxide to this gel. Great question. So OTC hydrogen peroxide brown bottle is going to be 3%, and it's going to be super low pH, and it will have this wow activation. It's going to break down into oxygen and water really, really fast. On a graph, it looks like this. Gel, Perio gel is very different. It has that slow linear rate of activation. You stick in the tray and turn it upside down. It doesn't go anywhere. It's really dense and gooey. It's 1.7% as opposed to 3%. It has a much higher pH, and it still is OTC. You can buy it directly from us and resell it to your patients. Your patients can also find this out. It's 8:30 my time. We're at the bottom of the hour. So I just want to thank you all for your interest in helping your patients save their teeth and their gums, keep them healthy. Thanks so much, Dr. Roling, for having us today. We're really proud to support this event.
Thank you so much, Tanya. Dr. McEwen says thank you as well. And I want to remind everybody, this is your opportunity. You have a ready patient base for you. These patients need you. I see Dr. Aiken. I'm going to congratulate him on taking the next step after retirement, I guess, to treat this patient population. And certainly a system like this works really well. In some cases, you're going to be training caregivers to use the product, but it definitely is going to help, between those visits. So thank you all for being here this evening. I'm going to close out. You will be redirected to a screen to complete a quiz for CE credit. You'll also receive an email from us here in just about a minute. For those of you that didn't have an opportunity, if you want to reach out to Tanya, if you tap on the banner at the top of the screen, you can bookmark that link for you. It's going to take you to their website. You just tap on the blue banner and save it for later. Thanks so much for being here. We hope to see you tomorrow night. The course is on xylitol, so it's a good follow-up. Saturday, we do have a course on infection control, so check out the website. Thank you so much for being here.